So Shahin Moledin. Now, what's the current landscape of treatment and what is the standard of care in pulmonary hypertension? Is it still debatable? And we know everybody keeps on starting just sildenafil, bosentan, right, left and center. So let's hear from you.
Thank you very much, and thank you also for the promotion, because I'm just Dr. Moledin. I'm going to. I thought a little bit about how to do this talk. Prashant asked, is the standard of care debatable, but mainly focusing on whether to go for single upfront combination therapy versus sequential combination therapy. And there are quite a few considerations on this. Maybe I don't have anything interesting in that segment of any of my slides, so we should manage fine just without it. And I thought I would just go from what I understand of the data and constraints in the UK, because any different constraints which are faced on access to drugs, I think you have a much better understanding of than I could presume to have. So combination therapy, I'm going to just talk very briefly about the disease itself and the rationale for combination therapy or sequential therapy, current treatment, how they've been used in combination, a comment about making the right choice of therapy, and then what do you do after that? So very briefly, pulmonary arterial hypertension is an aggressive disease. Most patients already have significant vascular disease by the time they present. We mentioned yesterday the Japanese screening study of ECG detected pulmonary hypertension. So these patients were screen detected asymptomatic patients, yet they already had a vascular resistance, I think it was 12 Wood units at diagnosis. So and they were no more likely to be responders, so they already had quite advanced disease by the time of diagnosis. It's also very aggressive in terms of, if you think of as a cancer paradigm, this is cell replication. These are data from one of Professor Howarth's PhD students back in 2010, looking at cells derived from explanted lungs at the time of transplant and the rate of proliferation. And you can see that children's cells proliferate even more rapidly than adult cells from idiopathic PH. And this is a slide from the BREATHE-5 study, which is quite old now, but the point of the slide is that there was a delay. The patients were allocated to therapy or placebo, and then at the end of, I think, 16 weeks, they were allowed to swap from placebo to active therapy, but they never managed to catch up, even the 16 weeks that they'd lost. So you don't always catch up what you've lost. The disease is relentless. These old, close to natural history data showing how quickly the survival curve falls off, median survival less than a year in pediatric pulmonary hypertension. And for the last decade or more, we've been treating three main pathways, which you're all familiar with: the endothelin pathway, nitric oxide pathway, and prostacyclin pathway. And yet we're not aware of any data to suggest that in particular patients one pathway is more affected than another. All the data suggests that in patients with established disease, all pathways are dysregulated. So we don't have a endotype of patients who are nitric oxide type of patients and endothelin type of patients and prostacyclin type of patients. Nevertheless, therapy has made an improvement, and these are now old data from Professor Barth's group. So things have been going well when we compare them to the historical standard, but by anyone's definition, 74% survival at 5 years is not something we desire for our children, and I think we should probably strive for better, and do. So people have looked back at various combinations of therapy, and this is data which combine the Dutch registry, New York and Denver registry, retrospective pediatric data, which suggests on the Kaplan-Meier curves that combination therapy is superior to monotherapy. However, these types of Kaplan-Meiers, we've produced one from the UK cohort as well, and Reveal has produced one as well, but they all suffer from a similar limitation in that to get to triple and combination therapy, you have to survive long enough to go through monotherapy. So there's survival time bias built into these. So it's not a prospective trial, and it has biases which favor combination therapy. So this paper I would recommend anyone to read. It's a really nice network meta-analysis. So over the years, there have been numerous randomized controlled trials in adult pulmonary hypertension. Now I think most of the randomized trials, except for one, will be in adult patients, and we're going to focus on randomized trials because they're the highest quality of data. So this is a network randomized controlled trial where they looked at network meta-analysis of all the randomized controlled trials, where they looked at all the possible comparators and produced this network of various comparators, and to see which combinations or which drugs are better than others. So what you end up with is something that looks complicated at first sight, but if we read across, you're comparing endothelin receptor antagonist against endothelin receptor antagonist plus PD5. So the hazard ratio is 2 to 1. So if you're on endothelin receptor antagonist versus an ERA plus a PD5, your chances of developing a clinical worsening event are twice as high, or your rate of developing a clinical worsening effect is twice as high. Unsurprisingly, combination therapy is much more effective than placebo. But you can see already from this comparison of all the randomized control trials published up to 2017, the combination groups are better than the monotherapy groups when you compare to endothelin receptor antagonists or oral or inhaled prostanoids. But not all combinations are the same, or not necessarily the same, and mainly when we're talking about combinations, I haven't included epoprostenol yet in this, but we're talking about the oral combination therapies. So not all combinations are the same. This is data from the Ambition study, which compared upfront combined ambrisentan and tadalafil with either upfront monotherapy with tadalafil or upfront monotherapy with ambrisentan, and showed that the combination therapy in a randomized fashion was superior. However, two studies of sildenafil and bazentan, this one with sildenafil added to stable bazentan background, and this one with sildenafil added to stable bazentan background, showed no efficacy. So combination therapy is different. Different combinations have different efficacies, and the data to support combination sildenafil and bazentan is much weaker than the data to support other combinations, which include ambrisentan and tadalafil, epoprostenol, sildenafil. So I'm not even giving you a balanced view. I think in view of the data supports combination therapy, dual combination therapy up front. However, the data also shows something else. It's an uncomfortable fact, but it comes shining through the data, and that is that where possible and where available, intravenous prostacyclin is superior to all of the other therapeutic modalities so far. So it's the only therapy which is superior. The dark pink means it's statistically significant. It's the only therapy that's superior across the board. And this therapy has been around for a long time. It has very many challenges with it, not least the cost, but has been shown in quite a nice natural experiment to improve survival. And we can go beyond dual combination therapy to triple combination therapy. These are data from Paris, where they open label took a group of adult patients and gave them upfront epoprostenol, ambrisentan and tadalafil, and showed sustained improvement in 6-minute walk tests, and very interestingly sustained and quite significant falls in pulmonary vascular resistance. And I understand from the last time I heard Professor Sitbourne talk about the data that out at about 3 years they still had 100% survival. So one possible strategy looking at the data would be to go up front with a combination of therapy, choosing the right combination of therapy based on what's available and what's effective, while waiting for novel therapies to be developed, because none of these therapies, however good they are curative. And I think on that I'll finish, and hopefully we won't be too far over. So pulmonary hypertension is aggressive. Our current strategies are limited. We have some powerful medications, but we still have to wait for more advanced therapy. Thank you very much.